Hi, everybody. You are listening to the MedEA podcast series. MedEA Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today, we are going to speak with Professor Felix Mahfoud, Chairman of Cardiology, University Hospital Basel, Switzerland, about the best practices for diagnosis and management of patients with heart failure with preserved ejection fraction. This podcast is part of the continuing medical education program entitled Blended Learning Journey on Cardiovascular Disease and Hypertension. The target audience for this program is cardiologists, internists, general practitioners, nurse practitioners, and other healthcare professionals who manage patients with hypertension and heart failure.
So, hello, my name is Felix Mahfoud. I'm Professor of Medicine and Chairman of Cardiology at University Hospital Basel. It's my privilege to discuss with you best practices for diagnosis and management of patients with heart failure with preserved ejection fraction during today's podcast. At the end of this podcast, you should be able to, first, analyze ejection fraction to distinguish heart failure with preserved ejection fraction from heart failure with reduced ejection fraction. Second, identify treatments and medication classes that effectively improve heart failure with preserved ejection fraction outcomes. And three, describe the prognosis and mortality risk of patients with heart failure and preserved ejection fraction. So let's start and discuss a couple of very important aspects related to the management of patients with heart failure and preserved ejection fraction.
Can you describe the differences between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction?
There's an important observation that we all have to acknowledge when discussing about heart failure, and that is that heart failure itself is a clinical syndrome that describes an entity of symptoms that patient occur because the left ventricle is not able to supply the body with enough oxygen. And this is mainly dyspnea, fatigue, and exercise intolerance. According to the ejection fraction of the left ventricle, we define patients as having left ventricular ejection fraction below 30% being heart failure with reduced ejection fraction. Left ventricular ejection fraction 41 to 49% is what we call mildly reduced ejection fraction, or HFmrEF. And those patients with a left ventricular ejection fraction above 50%, per definition, suffer from heart failure with preserved ejection fraction, or HFpEF. It's very important to recognize also that patients with an improved ejection fraction are those patients who previously had a baseline ejection fraction below 40%. And because we're doing a very good job in these patients, for instance, because we have them managed with optimized heart failure therapy, those patients over time, we do see an improvement of left ventricular ejection fraction above 50%. And this is now termed heart failure with improved ejection fraction, or HFpEF. In those patients, it's very important to not discontinue heart failure therapy because we have learned that here, once discontinued, very importantly, in 44% of those patients, ejection fraction can be worsened again. So take-home message number one is heart failure with improved ejection fraction is very different from heart failure with preserved ejection fraction, and is also different from heart failure with mildly reduced ejection fraction, or HFmrEF.
How does treatment differ depending on the form of heart failure that a patient has?
Once heart failure has been diagnosed with the typical symptoms a patient presents, but also echocardiography findings or elevations in natriuretic peptide, we have to initiate management of these patients. And there are medications that should be initiated that are being started irrespective of the ejection fraction in patients with diagnosed heart failure. And these are diuretics for fluid management and SGLT2 inhibitors, which are also recommended across the left ventricular ejection fraction spectrum of patients presenting with heart failure. Now, getting a little bit more detailed information on how to initiate escalate therapy in patients with heart failure and reduced ejection fraction is here we have 4 strategies, drugs that should be initiated at best simultaneously once the diagnosis has been made. These are ACE inhibitors, angiotensin receptor neprilysin inhibitors, beta blockers, mineralocorticoid receptor antagonists, SGLT2 inhibitors, and diuretics. Of course, we have to be a little careful in patients with hypotension and impaired left ventricular ejection fraction. Escalation of pharmacotherapy may induce hypotensive episodes, which is why careful uptitration of medication is very important. But please bear in mind that this management strategy of patients with heart failure consists of multiple drugs that interact at various mechanisms involved in the disease development and progression. In patients with heart failure and mildly reduced ejection fraction, we use, again, as a class 1 recommendation, diuretics and SGLT2 inhibitors, and as a class 2 recommendation, because the evidence in that spectrum is a little sparse, ACE inhibitors, ARNIs or ARBs, mineralocorticoid receptor antagonists, and beta blockers. And in patients with heart failure and preserved ejection fraction, there were a lot of studies being conducted investigating proven therapies in heart failure with reduced ejection fraction, that being beta blockers that didn't work well in patients with heart failure and preserved ejection fraction, ACE inhibitors and ARBs, they didn't prove to be beneficial in patients with heart failure and preserved ejection fraction, and also mineralocorticoid receptor antagonists didn't improve morbidity and mortality in patients with heart failure and preserved ejection fraction. Luckily, SGLT2 inhibitors very recently showed in 2 large outcome studies that they not only improve symptoms, but also reduce cardiovascular morbidity in patients presenting with heart failure and preserved ejection fraction. So this is really a cornerstone of the management of patients with heart failure and preserved ejection fraction. The data for ARNIs in HFpEF is a little mixed, not very clear. The large study conducted there didn't prove to reduce the primary endpoint across all patients included in the study. So it can be used, but it's not a class 1 recommendation. But what is a class 1 recommendation is, of course, the treatment of the underlying etiology, and of course, to treat cardiovascular and non-cardiovascular comorbidities in patients with heart failure and preserved ejection fraction. So for sure, when we see a patient with hypertension, that blood pressure has to be controlled according to current guidelines. In most patients, we try to reach a blood pressure of 120 to 130 for systolic and 70 to 80 for diastolic blood pressure.
Can you describe the prognosis and mortality risks of patients with heart failure with preserved ejection fraction as compared to patients with heart failure with reduced ejection fraction?
Well, we have learned from large studies and epidemiology data that there is absolutely no difference in terms of outcomes, cardiovascular morbidity and mortality in patients with heart failure and reduced ejection fraction as compared to heart failure with preserved ejection fraction. Despite the fact that ejection fraction is very different, both entities have high cardiovascular morbidity and mortality. So it's very important that we treat patients with heart failure and preserved ejection fraction as intense as we treat and follow up patients with reduced ejection fraction. And again, this contains of multiple approaches, including initiation of therapy. We discussed the pharmacotherapy that is available, but also treatment of comorbidities. And I mentioned hypertension, but also diabetes is very important, and lipid disorders, or these comorbidities have to be treated according to current guidelines, because we have learned that patients with heart failure and preserved ejection fraction have the same poor prognosis as patients with heart failure and reduced ejection fraction.
Are guidelines for treating heart failure with preserved ejection fraction really applied in frontline care? Where do you think there is a real medical need?
It is estimated that around 50% of patients with heart failure have heart failure with preserved ejection fraction. And we have already discussed that heart failure with preserved ejection fraction is associated with multimorbidity. And many of these patients really have significant comorbidities. Those comorbidities are, for instance, hypertension, diabetes, chronic kidney disease, atrial fibrillation, and chronic pulmonary disease. These comorbidities have to be managed according to current guidelines. That's very important in the management of patients with heart failure and preserved ejection fraction. And then when looking into the morbidity and mortality of patients with heart failure and preserved ejection fraction, one can recognize that despite the availability of the drugs that we already discussed, diuretics for fluid retention and SGLT2 inhibitors to reduce morbidity and heart failure hospitalization, the residual risk of these patients remains up to 20%. So, important drugs that can improve the prognosis of patients, but they are still leaving those patients with a residual risk. And this is what we have to tackle. Number one. And number two, when looking into current studies, one can see that at best 50% of patients with heart failure and preserved ejection fraction are diagnosed and treated according to current guidelines. So there's a huge unmet need to discuss the advantages of heart failure treatment with colleagues, but also with patients so that they are aware of their disease and that they adhere to the medication, the interventions, lifestyle interventions that we prescribe.
What take-home messages do we have at the end of this podcast?
First, there is no difference between prognosis and mortality risk for patients with heart failure and reduced ejection fraction as compared to heart failure with preserved ejection fraction. So careful management and follow-up of these patients is very important to improve their prognosis and to reduce cardiovascular morbidity and mortality. Secondly, we have discussed the importance of diagnosing heart failure with the symptoms of a patient with typical echocardiographic findings, but also elevations in NT-proBNP. And once the diagnosis has been made, treatment has to be initiated. And treatment depends on left ventricular ejection fraction, at least in part. We know that there are drugs recommended irrespective of the underlying left ventricular ejection fraction. And in all patients presenting with heart failure, diuretics are recommended and the use of SGLT2 inhibitors is recommended. And then according to left ventricular ejection fraction, we know that, for instance, in patients with reduced ejection fraction, the treatment contains ACE inhibitors and ARNIs, beta blockers, mineralocorticoid receptor antagonists, and, as mentioned, diuretics and SGLT2 inhibitors. In patients with heart failure and mildly reduced ejection fraction, diuretics and SGLT2 inhibitor, again, irrespective of the ejection fraction. But on top, guidelines recommend that we could consider ACE inhibitors, ARNIs, ARBs, mineralocorticoid receptor antagonists, and beta blockers. So treatment is pretty much in line with the recommendations for patients with reduced ejection fraction. And in patients with preserved ejection fraction, again, diuretics and SGLT2 inhibitors, irrespective of the underlying ejection fraction, but also the treatment of potential comorbidities that are present. For instance, hypertension, diabetes, and hyperlipidemia. All these comorbidities have to be treated according to current guidelines, and if possible, the etiology responsible for the heart failure with preserved ejection fraction should be treated as well.
Thank you for listening to this MedEA podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.